So we're using Maria as our proxy patient, and we're going with what we consider the easiest gap to close because it is relatively simple from a documentation perspective. I would say the biggest challenge is often overcoming patient objectives. So Maria has a statin gap. She also has diabetes. So that gap is considered an open gap. She's 62 years old. She's type 2. Um, she has been prescribed 3 times for the last 18 months. She filled once, discontinued after 2 weeks, citing muscle pain. And her PCP has tried education materials, follow-up calls, alternative dosing schedules. Nothing's worked to convince Maria. This is exactly the type of organization that we're outreaching to today and working with on a regular basis to solve these care gap closures. And many of you are probably aware that RistMD started out as an e-consult and later a v-consult company with the merger with Sitka. That is one of the tools that we use to close care gaps, but it's not the only tool. RistMD is now operating at full longitudinal care programs to support things like cardiology. And so when we think about some of the organizations we work with, here we're looking at a example or fictional organization, but the patient itself is pretty typical and follows what our common pattern is. And the patient population is about 75,000. They have 1,200 participating providers, lots of different touch points. And I will say that one thing that we see occurring is a drug will get prescribed in the hospital. The PCP may not know about that prescription. The patient may not be filling that prescription post a cardiac surgery or cardiac inpatient monitoring. And so one of the things that we often do is connect that data on the PCP's behalf and make sure that they're informed. So one open gap has haunted the dashboard for 18 months. That is the statin gap. PCPs are spending about 15 minutes per visit on statin counseling. It's a tremendous burden for that PCP, but quality scores are suffering, patient outcomes are suffering, and bonus dollars are at risk. So anytime that you're working within an MA population or any value-based payment model, this is an important gap to focus on. And what Xanth's team and what we'll get into later has accomplished is providing assistance, really, so that PCP doesn't have to do as much of the administrative research work to get it all done for Maria. So here's the turning point and why organizations reach out to us. Before a routine follow-up, we've tried having the PCP do the direct outreach as an organization. Acme Health has educated their PCPs. The PCPs want to get these patients on a statin. They've reached out to us. We review the full case history. We provide the PCP with recommendations, some additional education directly for the patient, and citations, I think useful for both the patient if they want more details, and particularly useful for the PCP. So like every PCP, you're treating thousands of patients on your panel, and you have to keep up with every specialty. So when something changes in a specialty, it's almost impossible to keep up with every single possible new research study that comes up in that specialty. That's what our cardiologists are here to support. So on the right-hand side, you can see the RistMD cardiologist has recommended a switch to a different statin and recommended the introduction of CoQ10 with a specific dosing strategy to address that muscle complaint for the patient. Also emphasize, and again, this is very abbreviated. Anybody that's ever seen any consult from us will see a lot more detail, but providing some of those patient benefits. It's a 25% reduction in risk of a heart attack. There's a decreased risk of stroke by approximately 20 to 25%. So that, showing to the patient, like, this has real value for you. This can keep you out of the hospital. This can help you maintain good health and be active and healthy throughout your retirement. Mm-hmm. So the next step is the patient, the PCP does another intervention with the patient. The PCP communicates the specialist recommendations, perhaps even shows the e-consult. It is part of the patient's chart, so it's perfectly acceptable to do that. Maria agrees to try the new approach. The outcome is the care gaps closed. What may not be seen is the follow-up that Arista MD is doing. Xan's team in particular is monitoring to make sure that gap remains closed, so that if that patient then doesn't fill the prescription again, that while the gap may be closed officially for the year and the star rating may not be impacted, your long-term cost of care as a Medicare Advantage participant or anybody participating in a value-based care knows that if Maria doesn't remain on the statin, her risk of heart attack or stroke goes up, and that could lead to an emergency room visit or an inpatient stay. And so we don't want to just close the gap. We understand that has tremendous value, but we want to keep that gap closed as well. So we're going to be continually monitoring Maria to make sure that gap's closed. Now, we say that all of our current programs operate that way. However, if an organization comes to us and says, okay, once the gap's closed, I don't want you to monitor them anymore, we are willing to do that. It's just not our recommendation because we're really focused on patient care. And then it's also the multiplier effect. The PCP is going to successfully replicate this approach with 12 other statin hesitant patients. And then your average time to gap closure, it drops from 6 months to 45 days. And one of the ways that we do this is with pre-appointment planning.